Good morning, everyone. Welcome you all for another wonderful session. And we would like to apologize you because there was some technical issue in the morning. And meeting you all after the gap, this is very happy to see you. And we are also meeting you on a very good topic today. Topic will be more helpful for all our members, so that it will help everybody in their day-to-day life. Actually, okay. So when we shortlist this topic and the speaker, Gautam was one of the very experienced, already having 4 years of experience, and currently is working in medical American Hospital, Dubai. He is holding a bachelor degree in anesthesia technology, which is giving him a more strong clinical foundation for his current day-to-day work. His expertise lies in interpreting complex medical documentation with precision and aligning it with accurate CPT guidelines. So, known for his anatomy-driven approach and meticulous attention to detail, Gautam is very much passionate about bridging the gap between the clinical insight and coding accuracy. So, his commitment to continuous learning and collaborative communication, it reflects his dedication to excellence in evolving in the field of healthcare documentation. So because of this, we feel as a he is a very good speaker, and he is a more appropriate person for this topic. And finally, when we look into his slides and his presentation, it has very vast information is there, which as a coder, whoever wants to learn from basics, actually, even if you're not a otolaryngology surgical coder, still, yeah, if you attend this session, that will be starts from basic, and it will give you an extensive knowledge in the face surgery, right? So Gautam, the stage is yours. Please go ahead. Actually, also before going into the session, I would like to thank Mr. Abil, who is one of our strong support. I can say he is a pillar for us. So whenever there is a need, he used to help us with all the topics or even speakers. He is more supportive to us every time. So thank you, Bill. And I would like to call Gautam to take the stage.
Uh, am I audible now? To be here with my fellow professionals. My name is Gautam, and I'm a certified medical coder currently working at American Hospital Dubai. First, I want to start by thanking the Abu Dhabi local chapter and the organizing team for giving me a chance to speak on this occasion, especially to Mr. Sheikh for his wonderful support. And I also want to thank you, everyone here, for taking the time to join today's session. I'm really happy to be part of this gathering and to share what I have learned. So, today we are diving into a topic. Okay, let's start. Today, we will be diving into a topic, functional endoscopic sinus surgery, or you can say it FES. Now, I know ENT procedures might not always be the most glamorous part of our coding day, but to be honest, when it comes to FES, it's different. It's very layered and technical, and it's one of those procedures where our coding skills truly shines. So in this session, I'm going to explain how procedure like FS challenges us. We will be checking the CPT codes and we'll try to interrupt documentation precisely. When we talk about FES, it's a multi-layered intervention that's designed precision from both surgeons as well as for coders. It's normally performed to treat chronic sinus conditions that don't respond to any medications. And as it involves multiple sinus groups, laterality, tissue removal, coding it accurately is very essential for proper reimbursement and compliance. So if there is an incorrect coding, it can lead to denials, audits, or underpayments. But more than that, more importantly, it can misrepresent the clinical work done by our surgeons. So that's why understanding FS is not just a technical skill, but it should be considered more as a professional responsibility. For example, let's imagine a typical scenario. We have a patient here, a 42-year-old woman. She has been suffering from chronic sinusitis for a long year. She have tried antibiotics, nasal sprays, and even allergy treatments, but nothing works. So she's here in our clinic with our ENT specialist, and as per the ENT specialist, he recommends FS surgery to open her sinus pathways and restore the normal drainage. Now here, as a coder, we won't be seeing the patient, but we do see the documentation, and it's our responsibility to translate that clinical story into accurate codes. That means understanding which sinuses were treated, whether there was a tissue removal, or if the procedure was done on one side or both the sides. We have to see the full picture of the scenario, and by analyzing that patient reports, we must capture the correct codes accordingly. So this is where our role become critical. So we must not think like we are just entering codes, but to be honest, we actually are reconstructing the surgical narrative. So to make the coding more interesting, not only for FES, for any surgery, if we are thinking like we are doing the surgery, then the coding will be easy. So when it comes to FES, to code FS correctly, we need to understand four main sinus groups like maxillary, ethmoid, frontal, and sphenoid. And as we know that each of these sinuses has distinct CPT codes, and also the complexity will be increasing when multiple sinuses are treated in one session. And also while coding FS, we used to come across different challenges, or we tend to make a lot of mistakes or confusions. We know there can be bundling confusion, uh, means some procedures are considered to be inclusive in other, and there might be a laterality error. That is, we might forget to put the laterality right or left modifiers, or we might be using modifier 15 correctly, which all can lead to a denial or a delayed payments. And of course, there are chances for unclear documentation that surgeons may not specify which sinus groups were treated or whether there was a tissue removal. So in such cases, we need to query the provider or the physician for much clarify. And we also used to face upcoding risk, like when sometimes we used to assign a higher level codes without enough documentation. For an example, like if we have coded for a tissue removal during FS, but there is no documentation about tissue removal, this can trigger an audit. So in this session, we will be discussing about the anatomy of nasal cavity and the sinuses, which are most important part in FS surgery. And we will be discussing the physiology of sinuses, And also we'll be discussing about the indications for FS. And at the end, this is the most important part, we will be discussing the guidelines related to FS codes. So what is FS? So in a simple words, FS can be described as a very minimal invasive surgery performed in case of a sinus blockage, normally to reverse the normal functions of our sinuses. Here we have a picture which shows how a typical endoscopic sinus surgery is performed. Here we can see the physician is using a fibro-optic scope to visualize the cavity of our cavity inside the nasal cavity, and he'll be using minute tools to remove tissues and concerned areas. A first surgery normally can be done under a local anesthesia or a general anesthesia based on the complexity. And as per the record, we can see that there is a in most of the case, there is a more than 90% of the success rate, and very less risks are involved in this first surgery. When checking the history of FS, we can see that prior to creation or adopting FS surgery, the standard treatment method was involved the creation of a surgical opening in the upper jaw or the teeth. Later, works of Professor Messenglinger changed the understanding that we can treat the diseases in the sinuses by highlighting the importance of endoscopic visualization and focus on functional drainage. With his studies on cadaver, he was able to clear the sinus drainage with very minimal tissue removal and without disturbing the internal structure of the nasal cavity. Later, after being exposed to the work of Professor Messenglinger, another professor, Dr. Kennedy, brought the technique of endoscopic sinus surgery into our modern medical science. He was able to develop his own techniques and instrumentations and named the procedure functional endoscopic sinus surgery. Now we will have a comparison between the traditional method and the modern FS surgery. First, when it comes to a FS surgery, the approach is always endoscopic. That means there won't be any external incisions required. And normally as there is no external incision, generally the recovery will be faster and there won't be much discomfort. But when it comes to an open surgery, it involves a larger external incision on the face or through the mouth. It will be utilizing more surgical tools to grasp the tissue around and to hold on the surgical area open. And of course, since it involves a larger external large opening, it can result in a scarring which will be visible on our face. And of course, there will be increased pain and other potential complications from the larger surgical trauma. So when we talk about FES, rather than as a surgery, FES is more like an approach. So through a FES surgery, surgeons can perform various surgeries based on the diagnosis. These FES procedure can include a biopsy, a polypectomy in case of a polyp, a removal of cyst, or to treat other structural abnormalities like that. And it mostly done to treat sinus procedures like ethmoidectomy, sphenoidectomy, and other treatment like a stent placement, and also in case of procedures like CS of leak repair, and the list goes on. We said that FES is a very high complex procedure requiring accurate coding for proper reimbursement. So in order to code it correctly, we should understand the sinus anatomy, and we should identify in which procedure, which sinus or the sinus group the procedure is done, and we also should apply CPT codes, guidelines and modifiers carefully. So for a medical coder, knowing the anatomy plays in very important role in our daily work life, not only related to FES, but for every procedure. To capture the correct codes, coder must know the anatomy of the surgical site. So now we will see why anatomy is crucial for a medical coder. Since we are all more linked to revenue management, let's start with the financial side. Errors in coding due to lack of anatomic knowledge can lead to incorrect billing, insurance claim rejections, and a significant financial loss for healthcare providers as well as for the patients. A single wrong CPT code could delay payments, can trigger an audit, or it might require a lengthy resubmission steps to get the payment. So if we are having a strong grasp on the anatomy, and by capturing the correct code accordingly, we can improve our accuracy, and not only the accuracy, but also it will have a financial benefits behind. And also in another scenario, in our daily work life, we know that knowing the anatomy can really help in communicating with our physicians, especially if you have a good knowledge and the familiarity with the anatomical terms and concepts allow us to speak the same language as that of a physician. This makes it easier to clarify ambiguities in case of any query requirements, or to ask, most importantly, to ask the right question at the right time, and which ensures that medical records are complete and precise. And instead of going back and forth for making assumptions, if you understand the anatomy and we have the confidence, which which will save our time as well the physician's time, and thus we can prevent errors in our daily coding work life. So we said that coding for FES requires knowing the anatomy of the nasal cavity and the sinuses, turbinates, and other structures in our surgical site. With that anatomical knowledge, it's easy to miss a critical detail, which can lead to incorrect code selection and reimbursement issues. So when we look into the anatomy of our nasal cavity, now here we will be starting with the nasal cavity. So we know that the nasal cavity is not just a passway of air, it's a space that filters, humidifies, and directs airflow. These are lined with mucosa and also rich in blood. So once we enter our nasal cavity, at the center, just like a wall, we can see the nasal septum. It runs through the midline of our body, dividing the cavity into left and right. Here we have a picture. Sorry. Here we can clearly see that the nasal septum, which is dividing the nasal cavity into two. We can see other structures along with it. So normally a septum is straight and there won't be any deviations. In case if physician found out that there is a deviation in our nasal septum, this is called a DNS, that is a deviated nasal septum. A deviated septum can obstruct a drainage and is most often corrected along with the FES surgery. Along the septum, we have the nasal turbinates. We have inferior, middle, and superior turbinates. So these are structures which helps in regulating airflow, which will create a turbulent flow, which helps to trap particles and warm the inhaled air, and which slows down and also it will slow down the flow of the air inside our nose. Like I said, we have three turbinates, or the turbinates are differentiated into three. They are inferior, and middle, and superior turbinate. Among the three, the largest turbinate is the inferior turbinate, and it is in the lowest part. And then comes the middle turbinate, which is a part of the ethmoid bone, and it lies between superior and inferior turbinates. When it's come to superior turbinate, it's very small in size, and it's also the part of ethmoid bone. Another important structure, which is meatasis. This lies along the turbinates. We have also, it's called it's just like an opening called meatasis. These are spaces underneath the turbinate where the sinuses drain. We know that in sinuses, it secretes mucus. From each sinuses, the mucus produced is drain out into our nasal tract through this opening. And when it comes to fes, the middle meatus is a critical area that we will be discussing in the later slides in more detail. When these meatus passages, or we can call it as a drainage channels, once it gets blocked, the mucus produced in the sinuses gets accumulated in our sinus, which will cause infections and then to a chronic sinusitis, which is why surgeon focus these meatasis on during the first surgery. They will be clearing these blockages to cure a sinusitis. We discussed that meatus is a key player. Why so? So in a middle meatus, it drains from the frontal, maxillary, and also from the anterior ethmoid sinuses. These are most involved in chronic diseases, and it's normally treated during FS surgery. Like I said already, when it gets blocked, it will result in mucus accumulation of these sinuses, and which will end up in a sinusitis. And in most of the cases, FS procedure will be targeting this area to open the natural ostia or the drainage to restore the normal ventilation and sinus drainage. We have first we will be looking into superior meatus, which is the pathway to the posterior ethmoid and sphenoid sinuses. Through superior meatus, we can safely reach into sphenoid sinuses by avoiding critical structures like skull base or optic nerve, which is very crucial as it avoids CSF leak or a optic nerve injury while doing FS surgery. Then we have inferior meatus, which lies beneath the inferior turbinate, which won't be playing a much role in FS as it's only opening for a nasolacrimal duct, which drains our TS from the eyes. So before we talk about coding and surgical techniques in FS, it is very, very important to understand the most important structure in FS surgery, which are the paranasal sinuses. These sinuses are air-filled cavities in the skull, which will help us breathe efficiently. And since each procedure performed in these sinuses has a distinct CPT code, as a coder, it also influences the CPT codes we used to choose while coding a sinus surgery. We know that sinuses are lined with mucous membrane and are very rich in blood vessels. These air-filled cavity connects to the nasal cavity through meatus, which is we already discussed, and it produces mucus that drains the nose, which helps in keeping it clear from germs and allergens. Since the sinus lining is continuous with the nasal lining, because of that, our sinuses have a tendency to get infections, which normally gets easily spread between other sinuses too. This will cause inflammation on the nasal lining, resulting in a sinus blockage, and which can obviously lead to a fist surgery. So when we talk about paranasal sinuses, we have four pairs. And we should also note that these sinuses are named after the bone which they reside. That means maxillary sinus is residing on maxillary bone. So we can easily connect those two, which will make our job easier. So now we will look into each sinuses. First, we will see into frontal sinus. These are located on our forehead within the frontal bone. They are triangular in shape, and the development will be little late in the childhood, usually around 7 years of age. Because of its location, procedure here requires more precision during a surgery. Next, we will be discussing the ethmoid sinus, which are found between the eyes of the bridge of the nose inside the ethmoid bone. These sinuses are unique because they are present at the birth, and it will be continue to grow with the age. Here in the picture, you can see the frontal sinuses in a green color, and below are the ethmoid sinuses. These ethmoid sinuses are multiple air cells. We can see three cells in blue color, which shows the ethmoid cells. So when it comes to surgical note, the doctor might say describe them as anterior or posterior ethmoid cells. These two terms will be directly affect our code selection. So while coding, if a surgery and if ethmoid is involved, we should look for these two terms, the anterior cells and the posterior cells. Then we have the sphenoid sinus, which lies very deep within our face, and it's positioned behind our nasal cavity. We can see in the picture it's shown in red color. Sorry. Sphenoid sinuses typically develop during our teen years, and since they are very close to critical structures like optic nerve and the brain, we can see in the picture they are very close to the cerebroform plate, and above we have the brain. From our birth, and it, this structure plays a critical role in both anatomy and especially when we are coding procedure like FSR, CSF repairs. These two structures plays a very important role. As cerebriform plate forms the roof of the nasal cavity and also acts as a floor for the brain. Because of its location, a cerebriform plate is very close to the ethmoid and frontal sinuses, and these are two areas commonly treated during FS surgery. And we should know that during FS surgery, if surgeon accidentally breaches this plate, it can lead to a FS leak, a CSF leak, that is a cerebrospinal fluid leak from the brain into our nasal cavity. These leaks are really serious. So if it's untreated, it can increase the risk of infection like meningitis. And when we have a CSF leak, of course, we will be going for another endoscopic procedure to treat the broken bones. Now, so far, we have discussed what FS is and how it was done earlier, and also the anatomy involved and the physiology. So now we have to see why AFS is done. Now we all know that AFS is a targeted surgery designed to restore our sinus drainage and ventilation. But to code it correctly and to ensure proper reimbursement, we must first understand why it's performed. That means the indication we should know. As a coder, while going through the patient records, one of the first thing we should look at is the indication or reason why the surgery is being done. So by knowing this will tell us that what surgeon is trying to fix. And from that, we can often guess what kind of procedure the surgeon is trying to do. Just for example, let's assume that while going through the medical report, we found out that our patient has a nasal polyp. Now we can expect that the surgeon will be removing the polyp, or there might be a tissue removal involved. Or in other case, if we see the problem is a blocked sinus, there might be a clinical requirement for an opening the sinus and cleaning it up. So let's by knowing the indication, we will be having a clue about what to look for the operative note. This will help us to code accurately and ask better questions to physicians in case of any missing documentation. And it also will help us to spot missing details in a operative report. For example, if the indication is very serious, like in case of that of a mucocele or a fungal infection, but the operative note is only discussing about the suctioning, we should expect that there is something off or the documentation is not so clear. So this understanding the reason behind the surgery makes things better at our job. So rather than just going through the reports and reading, we must clinically think and make sure the coding matches the care and that was actually given without any documentation deficit. So when we talk about the indications, the most common reasons for FS is a chronic sinusitis, or we can say a CRS. This condition typically persists inflammation of the sinus mucosa lasting approximately more than 12 weeks or 3 months, often accompanied by nasal congestions, facial pains, and impaired drainage, headaches, and the symptoms goes on. In case of a sinusitis, the surrounding tissues gets inflamed, which can be also accompanied by a nasal polyps. When we see there is a nasal polyps, the disease tends to be more diffuse, and we can often expect a more extensive surgical approach, especially targeting the sinuses like ethmoid and maxillary sinuses. And FES is also indicated in several other scenario like recurrent acute rhinosinusitis, ARIRS, and in case of some structural abnormalities like we have discussed the deviated nasal septum, or there might be a enlarged or a hypertrophic turbinate which can obstruct the drainage pathway. Then comes the other issues like a fungal sinusitis, particularly the allergic fungal sinusitis AFRS, which requires a surgical debridement to remove the fungal debris and restore the drainage. Other issues like a sinus mucocele, and in case of that of an orbital abscess, or if the patient is having a benign malignant tumor, this all represents a more advanced indication. These often involve the ethmoid and sphenoid sinuses with a more surgical involvement to the orbit and to the skull base. And like we discussed earlier, the FES plays a critical role in CSF leak repairs. In case if there is a CSF leak, the endoscopic access allows for a minimal invasive closure of the skull base to treat the CSF leak. Here we have a picture which shows the healthy sinus as well as the infected sinus. Here we can see the sinuses are filled with mucus, and we can see the red inflamed lining of mucus lining, and the passages here are very narrowed. So till here we have gone through FS surgery and the Coda's role in it. We have discussed its anatomy and the physiology and indications of FS surgery also we have discussed. Now we're gonna enter the main part of our coding journey. Today's session. In this session, we will be discussing how to decode FS surgery into CPT codes. We have seen the anatomy. Now we will be look into understanding the surgical pathways, the sinus groups involved, and how each intervention translates into precise CPT code. So as a medical coder, not only in FES, but coding any surgical procedure, it's important. It's more like a journey through the anatomy. So in case of a FES, as a coder, we need to understand the surgical pathways, the sinus groups involved, and the intent behind each maneuver. Let's see an example. Here we have a clinical documentation. The surgeon here opens the maxillary sinus and remove the polyps. So when we have a document like this, as a coder, I must ask that which sinuses are involved in this procedure, and was there any tissue removal, and also we should check whether it's is done on both the nostrils or for both sides, left and right. And at the end, we should land on the CPT. Here it comes the 31267, which is a maxillary androstomy with a tissue removal. So while going through the medical report, if you are missing any detail, like for example, if you are forgetting to code for a tissue removal or a misunderstanding the sinus involved, like instead of maxillary sinus, I have coded for a sphenoid sinus, there is a risk for undercoding, which will trigger an audit, and there will be a delay in reimbursement. When I say a delay in reimbursement, that means a loss in the revenue. We'll see another example. If the operative note says there is a frontal sinus opening and the mucosa are removed, and we are just coding 31276 without checking if there was a total ethmoidectomy performed along with the frontal sinus, we might miss the opportunity to build 31253 in here. So as a medical coder, our goal here is to decode with clarity, confidence, and clinical insights. So while coding a FS surgery, there are three major challenges, or let's say checkpoints, we have to see while coding FS. We know that we have multiple sinus groups, the frontal, ethmoid, and maxillary and sphenoid sinuses, and each one is having its own CPT codes, access routes, and coding rules. And we must check its laterality, whether the procedure was done on single side or the both side, and we have to use the modifiers accordingly. And also we need to apply logics in bundling, as some CPTs are bundled into other. And it's very important to know the hierarchy. If we don't understand the surgical hierarchy, there are chances that we might double code the procedure, or we might miss the bundled codes. So we will be beginning with the very basic. He will be discussing the diagnostic and surgical interventions in FS surgery. A diagnostic endoscopy is when a surgeon simply looks inside the nasal cavity and the sinuses. We should clearly check the documentation and make sure there must not be any other surgical interventions, but only just a visualization. But in other hand, when it comes to surgical endoscopy, it involves removing tissue, opening sinuses, and restoring the sinus drainage. And it's also important to note that if a surgery is done along with a diagnostic endoscopy, we must not bill both the codes, as the diagnostic endoscopy is always bundled with the surgical codes. For example, if the surgeon is using a nasal scope to view the nasal cavity and the middle meatus, and without any surgical intervention, then we can opt for CPT 31231. But if there is a removal of polyps from the ethmoid sinus, then this procedure becomes a surgical intervention. So in this case, we only should report surgical code like 31255. And for diagnostic FES, 31231 is the most commonly used. It's for nasal endoscopy of the nasal cavity and also for the middle meatus. It's very important thing to note is that unlike from other codes, this 31231 is bilateral by default. That means for a bilateral as well as for a unilateral procedure, we can use the same code and do not append any modifier. This applies only for the CPT 31231. Rest all the codes are either are unilateral codes. That means if the surgeon does the same procedure for both left and right, we have to use the modifiers accordingly. We'll see an example here. If the operative note says bilateral sphenoid endoscopy, we should report 31233 and we have to append the modifier 50. And in other case, if it's only on one side, we can report 31233 with either without a modifier or without using the appropriate for left and right modifiers. So to report a diagnostic phase, here we have three codes: CPT 31231 for a nasal endoscopy, which is treated in the diagnostic. Like we said, this code applies for both bilateral and unilateral procedures. Then we have 31233, which is for the maxillary sinoscopy. And we have 31235, which is for the phenol sinoscopy. Now we will move into a surgical territory. Here, these codes are represented with 31237 to 31298, varies based on the surgical site and the interventions. When we say surgical endoscopy, that means we all know that surgeon has done something in there. Either he might be removing the tissue or he might open the sinus drainage. He might be restoring the airflow. So in here, we must remember, like as we mentioned earlier, if there is a surgical procedure is performed, the diagnostic endoscopy is considered and is always considered as part of the surgery and is not coded or billed separately. Earlier, we have discussed that for FS, the coding is built on a hierarchical structure. We can say primary codes and the secondary codes. The coding normally is based on an actual pathway that the surgeon follows inside the sinus while doing the surgery. That means there are certain cases, or there are some sinuses which we can't be reached directly. Just for example, to get into the frontal sinus or sphenoid sinus, the surgeon mostly first pass through the ethmoid sinus. So he will be visiting the ethmoid sinus, look for any defects. In case of a defect, so he might be taking the cells from the ethmoid, maybe partially or sometimes a total ethmoidectomy to reach into the other sinuses and does the work there. As he does this because there is an already existing natural pathway, and because of this existing natural pathway, an ethmoidectomy is almost always the base procedure for FA surgery. Once the ethmoid is open, surgeon can proceed to treat other sinuses like frontal or sphenoid. And these, when we have these additional steps captured, we have to append secondary codes or bundle codes accordingly. So here, what I'm trying to explain is the ethmoidectomy can be considered as a foundation code on which other sinus procedures are performed. Here we have a picture of our sinuses, and we can see here in the green part is the ethmoid part. These are ethmoid cells. We have posterior and anterior ethmoid cells, and we can see these are tightly packed cells. So once we are in the ethmoid cells, and we always look into the sphenoid sinus by clearing the basal lamella and the turbinates. So now we will be looking into different surgical interventions performed on different sinuses. So first we will go with the ethmoidectomy. As the name suggests, it's a removal of diseased tissue and bone from the ethmoid sinus. Based on the tissue removal, we have two codes. Let's say we have two types: the partial ethmoidectomy and a total ethmoidectomy. So when it comes to an ethmoidectomy, while going through the operative note, we must look into three keywords, which are anterior cells, posterior cells, and basal lamella. We know that we have discussed earlier that sinuses are small air-filled cavity or cells, which are divided into anterior cell and posterior cells. First, we'll see the anterior cells. These are cells within the ethmoid bone located between our eyes, which are close to the frontal and maxillary sinuses. And we have seen the drainage while discussing the meatesis. And from the ethmoid sinuses, the mucus will drain into a middle meatus. Then we have the posterior ethmoid sinuses or cells. These are the cells which is located in the back of the ethmoid bone, and which are very close to sphenoid sinus and optic nerve, like other structures like optic nerve. And through meatesis, this will be draining into superior meatus. So if we are seeing while going through the medical report, if the only anterior cells are involved in a first surgery, then it's considered as a partial ethmoidectomy. And if the posterior or the basal lamella is involved in a first surgery, it has to be considered as a complete ethmoidectomy. So to clinically supported complete ethmoidectomy, the document must include the work done in a basal lamella to access the posterior cells of the ethmoid sinus. Otherwise, it can trigger audit and delay in payments. Here in this image, we can see the basal lamella which are very close sphenoid sinuses, and to clinically support the a complete ethmoidectomy, the document should have mentioned the work done in a basal lamella to access the posterior cells of the sphenoid sinuses. Otherwise, it will end up in a audit error. Now we have the sphenoidotomy. In here, the surgeon create or enlarge an opening into the sphenoid sinus, which endoscopically in FS surgery. It is done primarily to improve our sinus drainage. Through this, it's also possible to have a surgical access to the skull base in case of a tumor or a pituitary tumor, or in case for a CSF leak repair. In here also, we have two codes based on whether the tissue is removed or not. So if you are picking the code for tissue removal, we must make sure that it's clearly documented, otherwise it can trigger an audit. So normally, there is a common mistake we tend to make, or a point we must remember while doing coding of a sphenoidotomy is that the suctioning of a pus or a debris doesn't count as a tissue removal. So the operative note must say mucosa removed or the fungal debris cleared to justify 31288, which is the code for sphenoidotomy with the tissue removal. Just for example, if a surgeon opens a sphenoid end and suctions a pus, we should only report 31287. In other hand, if they remove a mucosa or a polyps from the sphenoid, we can report 31288. Then comes the combination codes. Here, first we will discuss about sphenoidotomy with ethmoidectomy. We already discussed that a sphenoidotomy and a frontal sinus exploration mostly performed along with the ethmoidectomy. Since these sinuses are naturally connected and tightly packed to each other, surgeon often passes through the ethmoid first to reach the other sinuses. So we must clearly look in the documentation to make sure that an ethmoidectomy is performed or not. If a surgeon performed only a partial ethmoidectomy and a sphenoidectomy, both these procedures can be billed separately as a distinct procedures. That means to reach into the sphenoid sinus, the surgeon has to either remove the ethmoid cells partially to have a good access to the sphenoid sinus, or he has to remove the entire ethmoid sinus to reach into the sphenoid sinus. When it comes to total ethmoidectomy, we have combination codes to available to build the service along with the sphenoidotomy. We have CPT 31257. We will be using these codes when a total ethmoidectomy and a sphenoidotomy for combined with a sphenoidotomy. We will be using this code when a sphenoid sinus is accessed and open, but there is no tissue removal. So we should always check for the documentation whether there is a tissue remover involved in it or not. And if there is a tissue removal involved along with ethmoidectomy and a sphenoidotomy, then we should capture the code 31259. And here also we have to use our bundle logic. Both CPT 31257 and 31259 are bundle codes. So we should not code both together. Then comes the maxillary sinus, and the procedure is called maxillary sinus endostomy, and the sinus involved is the maxillary sinus. Same like before, here also we have two codes, one for the drainage only and another for the pus or tissue removal. For example, if the surgeon opens the maxillary sinus and removes a polyps, that is a 31267. And if they just opens to drain the pus or to widen the opening, then we have to code only the 31256 without a sinus, without a tissue removal. So unlike from sphenoidotomy, there is no combination with ethmoidectomy here. So if you are seeing an ethmoidectomy and then maxillary endostomy together, we can separately bill those two codes. And it's very important to document everything clearly, and the document should support if there is any tissue removal done, or it is without tissue removal, or it was a pus or a debris, or there was a polyp removed. Accordingly, we have sorry. Now we have the frontal sinus exploration. Here we don't be having a separate tissue for the tissue removal. The CPT 31276, which will be representing both the tissue removal and for both the without tissue removal. Here, same like in case of a sphenoidotomy, ethmoid also can be involved. That means an frontal sinus exploration can be done as a standalone procedure or along with an ethmoidectomy. And based on partial and complete ethmoidomy, we have to capture appropriate code. That means if a frontal sinus exploration 31276 is combined with a partial anterior ethmoidectomy, we can use separate codes. Or if it is done along with the total ethmoidectomy, we have to use 31276. And like I said earlier, CPT 31276 stands for both tissue removal with tissue removal and as well as for without tissue removal. So here we don't have to look for that. Then we have other surgical interventions, that is repair of the cerebrospinal fluid leak. We have discussed about this in previous slides also. So here FES is used to repair the cerebrospinal fluid leak. While discussing the anatomy, we have discussed that we have a cerebriform plate, which is a thin bone-like part. Sorry, actually it's a bony part, which acts as a floor for the brain and also as a roof for our nasal cavity. Sometimes reasons like accidents, trauma, or an increased intracanal pressure, or due to complication from any surgeries, especially it can happen during a first surgery also. The skull base tend to have a leakage, and if this leakage is untreated, it can be results in serious health condition like a meningitis. So to treat this through FES, uh, surgeons use grafts and seal the leakage. And based on the leakage, so as far as as a coder we are concerned about the codes. So as based on the leakage site or the intervention site, we have two codes here, 31290 and 31291. When the leakage is in the ethmoid region, we have to capture the code 31290, which is for the repair of ethmoid and the ethmoid region. And when it's in the sphenoid region, we have to use 31291. So here one of the important point which we have to remember is that these two codes 31290 and CPT 31291 includes the exploration and repair. So ethmoidectomy or the work done in ethmoid as well as sphenoid sinuses is bundled with the CSF repair codes. So to report the CPT code 31290, which specifically covers the repair done in the ethmoid region as well, since the code includes the ethmoidectomy and the FES, the ethmoidectomy are bundled in the single procedure code. So we don't have to code it separately. And we should have the documentation very clearly saying whether the procedure is done in ethmoid region or the sphenoid region. Otherwise, it can again trigger an audit error and can delay the reimbursement. Now, another interesting procedure which we does through AFS surgery is the orbital decompression. This is not a everyday sinus procedure like other FES procedures, but here ENT surgeons use endoscopic access to treat the conditions like thyroid eye disease or an optic nerve decompression. In case of optic nerve decompression, it's normally done for patients with a Graves or orbitopathy, also known as thyroid eye disease. In patients with orbitopathy, due to the increased pressure, these patients have a bulging eye, which is called a proptosis, because the tissue behind the eye are inflamed and swollen. It will compress the eye and the surrounding structures, which will be causing a pressure on which can lead to a increased pressure on the optic nerve and damage. Sometimes this pressure will get so high that if it is left untreated, which can result in damaging our optic nerve, risking in vision loss, double vision, severe head pains, nausea, like that. So to relieve this pressure, surgeons has to remove the orbital walls, the bony structures around the eye, and sometimes the fat cells, and even sometimes both are removed. So as we discussed, it is done to create more space for the swollen tissues to expand. So thus in turn will help in reducing the pressure and it will improve the symptoms. So based on the technique, sorry. So based on the technique, here we have 3 codes. CPT 31292 for the middle or inferior wall decompression. And when it comes to 31293, both the medial and inferior walls are surgically removed or partially removed. And when it comes to 31294 is for an optical nerve decompression. Here, there are some points we should keep in mind that if a FS surgery is performing solely to reach the orbit, then we should not code the other FS surgery codes. But if there is a documentation that supports the patient is having sinusitis, which needed to be treated too, then we can use modifier 5059 to justify the sinus surgery performed along with the orbital decompressions. So let's see an example to make it clear. Here, a FES surgery is performed to treat the sinusitis to access the orbit. Here, the document clearly says the FES surgery is performed to treat sinusitis and also to have the access to the orbit to relieve the pressure. So here we can code both the FES surgery and as well as the orbital decompression codes. And like I said, here also the documentation is very crucial. The surgeon must give clinical indications in case if they are doing a FES surgery along with a decompression. It should clearly specify that that an ethmoidectomy or a maxillary androstomy is performed solely to treat other symptoms or diagnosis. That means if a standard first procedure like ethmoidectomy or maxillary androstomy or sphenodectomy is performed after the decompression or before the orbital decompression to treat any sinusitis or any sinus conditions, which can be reported separately. And here we will be using modifier 59. Now we will be discussing another surgical intervention, first with a balloon dilation. So rather than a surgical interventions, this approach merges a traditional endoscopic sinus surgery with furthermore minimally invasive method that uses a balloon catheter to gently dilate the sinus ostium. The sinus ostium is the drainage pathways. Here we have a picture clearly saying here a balloon is placed into the sinus cavity through the drainage pathway, and this will be inflated to dilate this area. This will clear the sinus pathways. When it comes to a balloon dilation, is particularly useful in case where an anatomical narrowing exists but tissue removal is necessary. This balloon dilation restores the drainage without disrupting any mucosa because it's furthermore less invasive surgery, making it ideal for frontal, maxillary, or sphenoid sinus cases. So while looking into a FES with a balloon dilation, we must make sure that no other FES surgical interventions are done on the same sinus. That means when a balloon dilation is performed without a tissue removal, we can use CPT codes 31295 to 31298 based on the specific site where the balloon dilation is performed. We have 4 codes here. When it comes to balloon dilation in a maxillary sinus ostium, we have to go for 31295 for dilation of maxillary sinus ostium with a balloon. Then we have separate code for frontal sinus ostium, which is 31296, and we have another code for sphenoid sinus 31297. So there should be a documentation which clearly stating which sinus is involved in a balloon dilation, and it should also mention as there is no other surgical intervention performed on the specific sinus. We must confirm that the balloon dilation was the sole technique used. There must not be any cutting, no tissue removal along with the balloon technique. On the same sinuses, if balloon dilation is performed along with the traditional FES surgery. For example, if you are dilating the maxillary sinus with a balloon, and we already did some tissue removal there. Instead of going for a balloon technique, we should append the traditional FES code in these situations. And we have one more code here, 31298, which is used when both the frontal and sphenoid sinuses are dilated using a balloon dilation method. Now we will look into another procedure, which is turbinectomy. These are procedures will be done through FES, which will be targeting the nasal turbinates. We have seen earlier that these are key structures which will be helping us to regulate the airflow and the humidification of our inhaled air. There are scenarios when these turbines get infected and become hypertrophied or obstructive. So a surgical reduction or a removal must be necessary. At first, before opting for FS surgery, the surgeon or the ENT specialist will always recommend for other medical treatments, especially the use of steroids or any anti-allergens to treat it medically. But in case of a failed medical management, this will finally ends up in a FS surgery. As we discussed earlier, we know there are three turbinates: inferior, middle, and the superior. When it comes to FS surgery and through FS, the inferior turbinates are most commonly addressed, especially in case of a chronic nasal obstruction or which is unresponsive to a medical therapy. A inferior turbinectomy is commonly used. So while coding a turbinectomy, we have to see which turbines are involved and the method used. The document should say whether the surgery was done on inferior, superior, or middle turbines, and it also specify the method used. So, for example, if the operative report says or it supports the use of techniques like a cryosurgery, diathermy, or echo ablation, this has to consider as an ablation procedure. And based on whether it's the intramural or superficial, we have to pick the codes. When it's done superficially with a cryosurgery or an ablation, we have to opt the code 30801, where the part of the turbines are removed superficially. Then we have code for intramural approach, where along with the tissue, we will be removing the bones also here. Here also, we can use 30802 when techniques like cryosurgery or diathermy or coablation is used to treat the inflamed turbines. In the image, we can see what inferior enlarged turbine will look like. Here we can see three turbines and the nasal septum. And on the right side, we can see one of the turbines are enlarged, which is inflamed. So you can see already the pathway to the nostrils are very thin or narrow. When we have a enlarged turbinate, it will further congest the area, which can then results in a drainage issue or blockages in the sinuses, which will tend to become into sinusitis. And for prolonged sinusitis, again, then we'll be ending up in FS surgery. Then we have another scenario where turbinectomy is done along with a submucous resection. Here we have to code 30140, and then we have other codes like 31240. We will be using it along with a concavulous resection, which is done into the middle turbinate. So here, while coding, the document should specifically specify which anatomy is surgically intervened and what are the methods they have used. It can be in inferior, middle, or superior, which will be determining the CPT codes. So documentation is very crucial to avoid audit errors and to avoid delay in reimbursements. Then we will be looking into septoplasty, which is often done along with FS surgery. We have seen the in anatomy section, we have seen the nasal septum, which is normally runs in a straight line along our medial line. Medial line, we can say it's a imaginary line that runs through the center of our body, which is dividing our body into both left and right. So a normal case, the septum is straight without any curvature or deviations. If there is a deviation, then it is called a deviant nasal septum. We know that the wall between the nostril are made up of, or the nasal septum is made up of bone and cartilage. When there is a deviation in the nasal septum, as you can see in the image, it can obstruct the airflow, which will cause nasal congestion and which will contribute to a sinus infection or a sinusitis or other dysfunction of a sinus. We can see here, just like that of a hypertrophic turbinate scenario, here also the nasal tract is already narrow. When we have a deviation of the nasal septum to either of the left or to the right side, this will create further congestion in that area. So due to this congestion, the nasal pathways or the meatus tends to get blocked easily, and these blocks can lead to mucosal accumulation in our sinuses and inflammation, and this will end up in a sinusitis. And if untreated, it can lead to much complex.
Shay, can you hear me?
Okay, okay. 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 Sorry for the break. I think there might had some technical errors during the session. So we'll get back into the topic. So during a septoplasty, the surgeon repositions or removes a deviated portion of the cartilage and the bone to restore the straight or the central alignment. Since the alignment becomes right, this will improve the nasal airflow and also supports the sinus drainages. We have told that septoplasty is often done along with the fess to clear the airway. So when it comes to the coding perspective, we don't have much codes here to discuss, which makes our job easier. We have only one code, 30520, which is used in case of a septoplasty, regardless of its technique. and it, and if it is performed along with other fist surgery or a turbinectomy of a sinus or any sinus surgeries during a fist surgery, the documentation must clearly support the medical necessity for each component. And as a coder, we should confirm whether the procedure was unilateral or bilateral and whether it was done for obstruction or access or both. Not for septoplasty, I'm talking about the other fist surgeries which were done along with the septoplasty. And these the other fist surgeries which you are doing along with the septoplasty can be coded or built if we have a specific clinical indication for those surgeries. So one of the another main point here we have to focus on is that if in a septoplasty they will be using a cartilage graft during the procedure. So as per coding guidelines and billing guidelines, we should not code the cartilage taken. That means you cannot bill this as an additional code for the graft. The preparation and collection of graft is already covered in the cytoplastic code. This we must keep in mind. So as far as now, we have seen the anatomy, physiology, city of the process. In ENT and FS coding, like I said, it helps to convey the full story, making sure that what we really happened, what will help us to convey the full story in a short form. Using them correctly protects the reimbursement. Some modifiers during FS surgery. Here, the procedure is done for bilateral. That means when it comes to FS, for example, if the ethmoidectomy performed on both the sides, we have to append the modifier 50 to the FS code. Or then comes the modifier 51, which we will be using the multiple procedures performed during a same surgical session. For example, if we did an ethmoidectomy and a sphenoidotomy and are performed the same session, and the ethmoidectomy is a partial, then we have to append modifier 51 along with the ethmoidectomy and sphenoidectomy codes. Then comes the modifier 59. It identifies the procedures which are not normally reported together or a separate and distinct from other procedures performed. So it will help this not only 59 modifier, or this modifier generally help us to bypass the NCC edits, and which help us in convey the full story of the procedures. For example, here for modifier 59, we'll see a first procedure performed on the same day, but separate from another procedure like an optic nerve compression we can append modifier 59 here. In earlier, while discussing the optic nerve decompression, we have come across the next example that a ethmoidectomy is performed solely to clear the sinuses issues along with the anoptical decompression. So in this scenario, we can use modifier 59 to convey that this ethmoidectomy done along with the optic nerve decompression is distinct, and so it will be get paid from the payer side. So then we have left and right modifiers. Just like in case of that of a bilateral modifier, when a specific sinus surgery is performed only in left side or only in right side, we have to use left and right modifier accordingly. We know some payers, especially like Medicare, request these modifiers to denote the specific side of the body on which the procedure was performed. So sometimes we if it is a bilateral, we can use the model 50, or sometimes some insurance companies will ask us to give both the modifier left and right as two separate codes. Okay, now we have seen main areas during FS surgery. We have seen the anatomy. We have seen our coding role in coder's role in coding FS surgery. We have seen the physiology, and we have seen the modifier used in FS surgery. Now, to make a more clear picture, we will be checking into few scenarios. First, we will look into a balloon dilation scenario here. As we discussed earlier, balloon dilation is a much lesser invasive procedure which performed to dilate the sinuses. So let's look into scenario number 1. Here, a 42-year-old patient comes with a frontal sinusitis, which is unresponsive to medical therapy. Doctor did a CT imaging, which confirms that there is a isolated or frontal ostium is obstructed. So here the surgeon performs a balloon dilation of the frontal sinus ostium and under the endoscopic visualization. Here there is no documentation of removal and there is no additional sinus interventions mentioned. So when we have such a scenario, first we should, as a coder, we should break the scenario into procedure types. When it's since it is a stress surgery, we should go for which sinus involved, and we should look for the technique, and we should look for the key documentation. Here, the procedure is a minimal invasive, that is FS, a functional endoscopic sinus surgery, and no tissue is removed. Here, the sinus involved is the frontus only. There is no other sinus. But we should always check whether it is whether there is any involvement of a ethmoid sinus or any procedure like ethmoidectomy is done along with it. But luckily here there is no other sinus involvement. Only frontal sinus is intervened during this surgical intervention. So here the surgical technique used is the balloon dilation, not a traditional FES. We have seen that balloon dilation is a further more advanced, less minimally invasive procedure done to dilate the sinuses. So since we know that we have already discussed in balloon dilation slides that if a balloon dilation is done without any traditional phase, we can go for the corresponding balloon dilation code based on which sinus it is performed. Since it is done in the frontal sinus, here we can append the code 31296. And as I said, based on the laterality of the procedure, whether it's done on right side or the left side, we can append the modifier RT or LT, or if it is done on both side or it's a bilateral procedure, then we can append the modifier 50. In the scenario, the main focus area is that only the balloon dilation is performed. There is no other traditional fist surgery involved on either to the adjacent sinuses or to the same sinuses. Now we will look into another hybrid approach where a balloon dilation comes along with a fist another traditional fist procedure. Here, if let's say, for example, a 14-year-old patient presents with an axillary sinusitis, and she also has a mucosal thickening. When doctor did the CT, he can see that the maxillary sinus are partially obstructed, and there is retained secretions or mucus secretion accumulation present in the sinuses. So during the surgery, the ENT surgeon performs a balloon dilation of the maxillary ostium. We have to note all these points to widen the drainage pathway. Followed by he also did an maxillary androstomy with a tissue removal because there is a diseased mucosa and other tissue abnormalities like polyps present. So in this scenario, both the interventions are performed on the same site within the same operative session. So when coding, first we have to break down the scenario. Here, the sinus involved is the maxillary only. That will make our job much easier. Only the maxillary sinus is involved. So here the procedure performed are balloon dilation to expand the ostium, and also surgeon did a traditional endostomy to clear the polyp. And we have the documentation which supports the both. Now, when it comes to technique used, he did a balloon dilation. We used a balloon to dilate the internal ostium of the sinuses, especially in here, the maxillary sinus. And also he did that traditional fist surgery to remove the tissues. So when it comes to poding, there are a few challenges. We should always remember that balloon dilation is always bundled when performed on the same sinus as a tissue removal, along with the tissue removal or the traditional fist surgery. Here, we have to choose 31267 nasal sinus endoscopy surgical with a maxillary androstomy with removal of tissue from the maxillary sinus. I hope it's clear for everyone why we have chosen this. So I will explain once again to make it sure that here in this scenario, yes, there is a documentation of a balloon dilation, but we are not coded that. Why? Because along with the balloon dilation, the surgeon also performed a surgical first procedure to remove the tissue from the same sinus. That means a balloon dilation plus a traditional fist surgery is involved in the scenario. So as per coding guidelines, we should not bill both the procedures, but we should only bill the traditional fist code, the 31267. And again, like before, we have to use appropriate modifier here based on left or right, based on the left laterality. And if it's in the if it is in the if it is a bilateral procedure, that means if the both right maxillary and left maxillary sinus are involved in the surgery, we have to use the modifier 50. Now we will check into one more scenario. We'll be quick as it's already the time. So here we will be checking a fist surgery, which is a little more complex, where it involves both maxillary androstomy and a nasal polypectomy. So here we have a 60-year-old patient with presents with the recurrent nasal polyps and also issues in the maxillary sinus. Her maxillary sinus are obstructed. When we check into the documentation, we find out that there was the clinical documentation support a total ethmoidectomy, and there is a maxillary androstomy with the tissue removal, and also the nasal polyps are removed. So when we break down, we know there's a traditional fist surgery along with the tissue removal. Here the sinus involved are ethmoid and maxillary. An additional procedure, he also did the nasal polypectomy. And here we have the documentation for each. We have the ethmoidectomy specified as a total. That means lamella is done, but actually the document has to be specifically mentioned the lamella is involved in this procedure to support the total ethmoidectomy. But we can just keep that aside and we can code further. So here we have we can come end up encoding into 31255 for the total ethmoidectomy done, and for the maxillary enterostomy 31256. But since nasal polypectomy and the ethmoidectomy are bundled together, we won't be coding it separately. And here also we can apply the laterality modifiers and the distinct procedure modifier accordingly. Right and left or 50 modifiers has to apply based on the laterality of the procedure. So far we have come across all the topics in this session. We have discussed about anatomy, physiology, and the different surgeries done through FES and the CPT codes and the guidelines we mostly use during FS surgery. So I strongly believe this section was really helpful and useful for everyone here. So we didn't just talk about codes. I believe that we explored the clinical thinking behind each CPT codes, and we discussed the anatomy, and we discussed the surgical intent of every surgical procedure, and we also discussed how a CPT code tells the story, especially when it comes to FS. So as a coder, here our role is to make the story clear, and it will only happens only can be achieved through understanding the anatomy and the reason behind each procedure. So with those knowledge, we can code the procedure with the full confidence and support a clean and audit-proof documentation. So from whether to choose from a right modifier to knowing the bundling logic or spotting the difference between limited and total, every detail matters in our coding lives, especially during ENT procedures like FES. So once we get it right, we help the clinicians, patients, and with that system, our RCM flow will work better. So by this, I would like to conclude today's session. So thank you, team. Thank you, team, for listening, for engaging, and being part of this session, and for being part of this learning journey. So let's keep going together. So I like to wish you all a great future ahead. Stay connected, and let's grow together. Thank you so much, guys. Thank you.